Hello everyone. So today, me and my partner Louzel Herlee Gonzaga will be presenting to you our report about pulmonary edema, cardiogenic shock, pericardial effusion, and cardiac tamponade. Just a brief anatomy review of organ or system involved. The main function of the circulatory or cardiovascular system is to deliver oxygen to the body tissues, while simultaneously removing carbon dioxide produced by metabolism. Oxygen is bound to molecules called hemoglobin that are on the surface of the red blood cells in the blood. Pulmonary edema is the abnormal accumulation of fluid in the interstitial spaces of the lungs that diffuses into the alveoli. Pathophysiology. Pulmonary edema is an acute event that results from left ventricular failure. It can occur acutely, such as with MI, or it can occur as an exacerbation of chronic HF. Myocardial scarring can limit the distensibility of the ventricle and render it vulnerable to a sudden increase in workload. With increased resistance to the left ventricular filling, blood backs up into the pulmonary circulation. The patient quickly develops pulmonary edema, sometimes called flash pulmonary edema, from the blood volume overload in the lungs. Pulmonary edema can also be caused by non-cardiac disorders, such as renal failure and other conditions that cause the body to retain fluid. The pathophysiology is similar to that seen in HF, in that the left ventricle cannot handle the volume overload and blood volume and pressure buildup in the left atrium. The rapid increase in atrial pressure results in an acute increase in pulmonary venous pressure, which produces an increase in hydrostatic pressure that forces fluid out of the pulmonary capillaries into the interstitial spaces and alveoli. Lymphatic drainage of the excess fluid is ineffective. Pulmonary edema clinical manifestations. As a result of decreased cerebral oxygenation, the patient becomes increasingly restless and anxious. Along with the sudden onset of breathlessness and a sense of suffocation, the patient's hands become cold and moist. The nail beds become cyanotic or bluish, and the skin turns ashen or gray. The pulse is weak and rapid, and the neck veins are distended. Incessant coughing may occur, producing increasing quantities of foamy sputum. As pulmonary edema progresses, the patient's anxiety and restlessness increase. The patient becomes confused, then stertorous. Breathing is rapid, noisy, and moist sounding. The patient's oxygen saturation is significantly decreased. The patient, nearly suffocated by the blood thing, frothy fluid filling the alveoli, is literally drowning in secretions. The situation demands emergent action. Assessment and diagnostic findings. The diagnosis is made by evaluating the clinical manifestations resulting from pulmonary congestion. A chest X-ray may be obtained to confirm the extent of pulmonary vessels and tissue engorgement. Abrupt onset of signs of left-sided heart failure may occur without evidence of right-sided heart failure.
Pulmonary edema medical management. Oxygen is administered in concentrations adequate to relieve hypoxemia and dyspnea. A face mask is used initially if respiratory failure is severe or persists. Continuous positive airway pressure may be tried. For some patients, endotracheal intubation and mechanical ventilation are required. The ventricular can provide positive and expiratory pressure, which is effective in reducing venous return. decreasing fluid movement from the pulmonary capillaries to the alveoli and improving oxygenation. Oxygenation is monitored by pulse oximetry and by measurement of arterial blood gases. Pulmonary edema pharmacologic therapy. Morphine. Morphine is titrated intravenously in small doses, 2 to 5 milligrams, to reduce peripheral resistance and venous return so that blood can be distributed from the pulmonary circulation to other parts of the body. This decreases pressure in the pulmonary capillaries and diffusion of fluid into the lungs and to the lung tissue. In addition, the morphine reduces anxiety, which is also beneficial. Diuretics. Diuretics promote the excretion of sodium and water by the kidneys. For example, furosemide is administered by IV push or as a continuous infusion to produce a rapid diuretic effect. Furosemide also causes the vasodilation and pooling of blood and peripheral blood vessels, which reduces the amount of blood returned to the heart. Other diuretics such as metolazone may be administered as second-line therapy. Intravenous infusion vasodilators, such as IV nitroglycerin or nitroprusside or nipride, may enhance symptom relief in pulmonary edema. As described earlier in the chapter, a constant continuous infusion of Nasiritide may also be prescribed for the patient with acute decompensated heart failure. Pulmonary edema nursing process. Positioning the patient. To promote circulation, proper positioning can help reduce venous return to the heart. The patient is positioned upright, preferably with the legs dangling over the side of the bed. This has the immediate effect of decreasing venous return, decreasing right ventricular stroke volume, and decreasing lung congestion. Providing psychological support. As the ability to breathe decreases, the patient's fear and anxiety rise proportionately, making the condition more severe. Reassuring the patient and providing skillful anticipatory nursing care are integral parts of the therapy. Because the patient has an unstable condition, the nurse must remain with the patient. The nurse gives the patient simple, concise information in a reassuring voice about what is being done to treat the condition and the expected. Last, monitoring medications. The patient receiving morphine is observed for respiratory depression, hypotension, and vomiting. A morphine antagonist such as naloxone hydrochloride or Narcan is kept available and given to the patient who exhibits serious respiratory depressions.
Let's move on to cardiogenic shock. Cardiogenic shock occurs when decreased CO leads to inadequate tissue perfusion and initiation of the shock syndrome. Cardiogenic shock may occur following MI when a large area of myocardium becomes ischemic and hypokinetic. It can also occur as a result of end stage of heart failure, cardiac tamponade, pulmonary embolism, cardiomyopathy, and dysrhythmias. Cardiogenic shock is a life-threatening condition with a high mortality rate. The pathophysiology of cardiogenic shock involves a vicious spiral circle. Ischemia causes myocardial dysfunction, which in turn aggravates myocardial ischemia. Myocardial stunning or hibernating myocardium can enhance myocardial dysfunction, thus worsening the cardiogenic shock. Clinical manifestation. Breathing problems including rapid breathing and severe shortness of breath, bulging of large veins in the neck, clammy skin, cold hands and feet, loss of consciousness, swelling of feet, urinating much less than usual or not at all. Assessment and diagnostic findings. Cardiogenic shock is usually diagnosed in an emergency setting. Doctors will check for signs and symptoms of shock and will then perform tests to find the cause. Tests might include, first, blood pressure measurement. People in shock have very low blood pressure. Second, electrocardiogram or ECG. This test records the electrical activity of your heart via electrodes attached to your skin. If you have damaged heart muscle, electric problems, or fluid buildup around your heart, it won't conduct electrical impulses normally. Third, chest X-ray. This allows your doctor to check the size and shape of your heart and its blood vessels and whether there's fluid in your lungs. Fourth, blood tests. You'll have blood drawn to check for organ damage, infection, and heart attack. Another type of blood test called arterial blood gas might be used to measure oxygen in your blood. Fifth, echocardiogram. Sound waves produce an image of your heart that can help identify damage from a heart attack. And last, cardiac catheterization. A liquid dye is injected into the arteries of your heart through a long, thin tube or catheter that's, that's inserted through an artery, usually in your leg. The dye makes your arteries visible on X-ray, revealing areas of blockage or narrowing.
Cardiogenic shock medical management. Correction of underlying causes. As well of forms of shock, the underlying cause of cardiogenic shock must be corrected. It is necessary first to treat the oxygenation needs of the heart muscles to ensure its continued ability to pump blood to other organs. Initiation of first-line treatment. First is oxygenation. In the early stages of shock, supplemental oxygen is administered by nasal cannula at a rate of 2 to 6 liters per minute to achieve an oxygen saturation exceeding 90%. Pain control is if a patient experiences chest pain, IV morphine is administered for pain relief. Hemodynamic monitoring is initiated to assess the patient's response to treatment. Laboratory marker monitoring. Laboratory markers for ventricular dysfunction and cardiac enzyme levels are measured, and serial 12 lead ECGs are obtained to assess the degree of myocardial damage. Fluid therapy. Appropriate fluid administration is also necessary in the treatment of cardiogenic shock. Cardiogenic shock pharmacologic therapy. The vitamin. It produces inotropic effects by stimulating myocardial beta receptors, increasing the strength of myocardial activity, and improving cardiac output. Nitroglycerin. IV nitroglycerin in low doses acts as a venous vasodilator and therefore reduces preload. Dopamine is a sympathomimetic agent that has varying vasoactive effects depending on the dosage. Other vasoactive medications. Additional vasoactive agents that may be used in managing cardiogenic shock include norepinephrine, epinephrine, milrinone, vasopressin, and phenylephrine. Cardiogenic shock therapy, pharmacologic therapy, continuation. Antiarrhythmic medications. Multiple factors such as hypoxemia, electrolyte imbalance, and acid-base imbalances contribute to serious cardiac dysrhythmias in all patients with shock. Mechanical assistive devices. If cardiac output does not improve despite supplemental oxygen, vasoactive medications, and fluid boluses, mechanical assistive devices are used temporarily to improve the heart's ability to pump. The nursing process of the cardiogenic shock. First is preventing cardiogenic shock. Identifying at-risk patients early, promoting adequate oxygenation of the heart muscle, and decreasing a cardiac workload can prevent cardiogenic shock. This can be accomplished by conserving the patient. administering medications and intravenous fluids. The nurse plays a critical role in the safe and accurate administration of IV fluids and medications. Maintaining intra-aortic balloon and counterpulsation. The nurse plays a critical role in caring for the patient receiving intra-aortic balloon counterpulsation. Enhancing safety and comfort. Throughout care, the nurse must take an active role in safeguarding the patient, enhancing, comforting, and reducing anxiety.
Let's proceed to our last topic, pericardial effusion and cardiac tamponade. Pathophysiology. Pericardial effusion or accumulation of fluid in the pericardial sac may accompany advanced heart failure, pericarditis, metastatic carcinoma, cardiac surgery, or trauma. Normally, the pericardial sac contains about 20 ml of fluid, which is needed to decrease friction for the beating heart. An increase in pericardial fluid raises the pressure within the pericardial sac and compresses the heart. This has the following effects: elevated pressure in all cardiac chambers, decreased venous return due to atrial compression, inability of the ventricles to distend and fill adequately. Pericardial fluid may accumulate slowly without causing noticeable symptoms until a large amount accumulates. However, a rapidly developing effusion can stretch the pericardium to its maximum size, and because of increased pericardial pressure, reduced venous return to the heart and decreased CO. The result is cardiac tamponade. Clinical manifestations. The patient may report a feeling of fullness within the chest or may have substantial or ill-defined pain. The feeling of pressure in the chest may result from stretching of the pericardial sac. Because of increased pressure within the pericardium, venous pressure tends to increase, as evidenced by engorged neck veins. Other signs include shortness of breath and labile or low blood pressure, systolic blood pressure that is markedly lower during inhalation is called pulsus paradoxus. Pulsus paradoxus is characterized by an abnormal difference of at least 10 mmHg in systolic pressure between the point that is heard during exhalation and the point that is heard during inhalation. The cardinal signs of cardiac tamponade are falling systolic blood pressure, narrowing pulsus pressure, rising venous pressure, and distant heart sound. Assessment and diagnostic findings. An echocardiogram is performed to confirm the diagnosis and quantify the amount of pericardial fluid. A chest X-ray may also show a large pericardial effusion.
Pericardial effusions and cardiac tamponade medical management. Non-steroidal anti-inflammatory medications or NSAIDs can be used to treat pericardial effusions caused by inflammation. These drugs include ibuprofen or aspirin. Diuretics and other heart failure medications can be used to treat pericardial effusions caused by heart failure. Antibiotics are used to treat pericardial effusions caused by an infection. If a pericardial effusion is related to the presence of cancer, treatment may include chemotherapy, radiation therapy, or medication infused within the chest. Pericardial effusion and cardiac tamponade nursing process. Assess for pulsus paradoxus. Monitor ECG tracings. Assess heart and lung sounds, neck vein feeling, level of consciousness, respiratory status, and skin color and temperature. Monitor and record intake and output. Review laboratory findings, for example, arterial blood gas and electrolyte levels. Elevate the head of the patient's bed to ease breathing. Minimize patient's physical and activity to reduce oxygen requirements. Administer supplemental oxygens as prescribed. Provide frequent oral hygiene. Position and encourage the patient to breathe and take deep breaths every 2 hours. As needed, maintain a patent intravenous access, reorient the patient, and provide supportive measures and appropriate patient instructions.